Good evening. I'm Ellis Dean, your host on blackdoctor.org. Thank you for joining us for this important conversation, one that could save your life. We're back with another panel in partnership with Cedars Sinai as we discuss the latest information about pancreatic cancer, including prevention, screening, diagnosis, and treatments. Today's discussion is also available via simultaneous interpretation in Spanish on our daily Vinamina Facebook page.
Not yet. Wait, slow down, slow down.
We're talking about pancreatic cancer because being African American is one of the risk factors for this disease. And because we know a diagnosis of pancreatic cancer can be overwhelming, but thanks to early detection and new treatments, there is hope. Our expert panelists today are here to discuss the latest screening tools and treatments to give our viewers all the latest information about pancreatic cancer. Let's talk about it. But first, let's meet our panel. We have Dr. Servanas, I think I'm saying that properly, excuse my southern drawl and tongue for that. Gadam is an interventional gastroenterologist, golly, say that 5 times real fast, gastroenterologist at Cedars Sinai. And Dr. Arsen Osipov is a medical oncologist also at Cedars Sinai, where he is a principal investigator in the Pancreas Cancer Research Group at the Samuel Ocean Cancer Center. We have Nanor Halajan, is a genetic counselor at Cedars Sinai, and we also have Don Cheatham, and he's going to share his personal experience as a patient diagnosed with pancreatic cancer and the treatments received. We've got a lot to talk about today, so let's get started. All right, so before we discuss pancreatic cancer, let's talk about the pancreas. What is the pancreas and what does it do in our body? Dr. Gadam?
Yeah, so most people that are attending here today probably know what the pancreas is, but there are a lot of people that don't. So it's a digestive organ. It's located in the upper belly, all the way in the back. It's a very soft, fleshy organ, helps with digestion and also produces insulin. Every day, we go about living our lives, eat our food, gets digested, and we never know or hear or talk about the pancreas. But when there is a problem, say acute pancreatitis, chronic pancreatitis, these are very painful conditions. But more importantly, pancreas cancer is a very aggressive cancer, has much lower survival. So the chance that somebody with pancreatic cancer can survive for 5 years is only about 10%, which is one of the most aggressive in terms of cancer. So today we are here to talk about pancreas and cancer involved. So I hope that helps.
Oh, absolutely. Absolutely. So Dr. Osipov, what are some of the risk factors for pancreatic cancer?
Well, when it comes to risk factors, I think there's really 2 ways of thinking about them. You have risk factors that are modifiable, things that we can change about the way we live, the things we eat, the substances that we may be exposed to. And then there are things that are non-modifiable, things like the genes that we inherit from mom or dad. Now, the things that are modifiable, common things, the big one that's a major risk factor for pancreatic cancer is smoking. And in fact, pancreatic cancer, even upwards of 30%, is associated with smoking. It increases your risk of developing this very aggressive tumor. Similarly, if you were to actually stop smoking, you could actually decrease your risk of developing pancreatic cancer by even 50%. That's a pretty big change, and something that, those people who are smoking and want to make an active lifestyle change, that's one thing that it could help immensely. Another common thing that affects our African-American community as well as much of the United States is obesity and physical inactivity. And those are 2 very significant modifiable risk factors that, patients that have a higher BMI or a little overweight, that leads to problems with insulin as well as the development of diabetes. And then those patients have a high risk of developing pancreatic cancer. Those are 2 real common ones, along with alcohol use is another one that's commonly known. But then there are non-modifiable risk factors. Those are things that we're born with, like the genes we get. Now, there are sometimes people hear, maybe even on the news or on TV, about the breast cancer gene or the ovarian cancer gene known as BRCA. But interestingly enough, in about 10%, 10 to 15% of patients with pancreatic cancer, these genes are also involved. And that's why genetic counseling and knowing your family history is really, really important, because if you know it, you can, interact with physicians and geneticists early on to avoid developing this type of cancer. And there are multiple other genetic conditions. Some of them have very fancy names, but the real things to think about are things like the BRCA mutations, as I mentioned. And the other really big factor that Dr. Gaddam sees all too often is patients that develop pancreatitis or inflammation of the pancreas. If you have chronic pancreatitis, that's another major risk factor for developing pancreatic cancer.
So, Dr. Gaddam, why is being African American a risk factor?
Well, I don't think we know the exact cause. There are several theories about it. It's probably something to do with the genetics, like Dr. Asifa was saying. It's carried through families and generations down, some of which we know, and there are probably many more we will discover in the coming years. So it may have something genetic that Nana can tell us more about today. There's also, it's possible that the type of environment, food that our African American colleagues are exposed to, the patients are exposed to, that may be putting them at risk for pancreatic cancer. Even though we don't know the exact cause, what we know for sure is that for the last I want to say, from when we started collecting data, maybe about 7 decades or so, we know that the risk of pancreatic cancer in African Americans is much higher than the other races, and also is trending upwards, meaning the incidence is slowly but surely increasing over time. We know that once we know that there's an increasing trend, I think we act on it. We come up with ways to be aware of it, aware of the risks, and try to make the diagnosis early. That would be the goal.
So for people, and Dr. Asapov, this is for you. So for people with other endocrine issues such as diabetes, is there a link to the prevalence of pancreatic cancer?
Yeah, this is a great question. It's a really important point. We've known for a very long time that there's a very significant association with having diabetes and having an increased risk of developing pancreatic cancer. But recently, there's been this question of sometimes, does pancreas cancer cause diabetes, or is it the diabetes that leads to pancreas cancer? And honestly, we think it's a little bit of both. Now, for patients who are overweight or have obesity or are not physically active and they end up developing diabetes, that causes a lot of inflammation or changes in the pancreas that increase your chance of developing pancreas cancer. But if you're someone that, you're in your adulthood and you don't have a history of diabetes, and all of a sudden you start getting diabetes and you're otherwise fairly active or fairly healthy, that could be a sign, one of the first signs that you might be having some change in the pancreas that might be concerning for development of a tumor. We know that patients that lose weight, have good physical activity, and thus don't develop diabetes, their chance of developing pancreatic cancer also goes down. So there's actually a connection both ways, both in developing pancreas cancer and pancreas cancer in and of itself causing diabetes. Somewhere around 80% of patients that have pancreatic cancer actually have simultaneous diabetes.
So Dr. Gaddam, what are the symptoms of pancreatic cancer?
So the unfortunate part of it is that most patients with pancreatic cancers don't have symptoms. And that's one of the reasons why people think that it's diagnosed late, is because it doesn't alert the individual to go and seek help. But then there are some very well-known symptoms. And of course, if anybody has these symptoms, you should be seeing your primary care physician or getting some medical help. These are very non-specific symptoms. They could be caused by a lot of things, but the constellation of these things occurring in one person sort of raises questions about pancreatic cancer. And these include having just unexplained weight loss, having just this nausea or vomiting, bloating, fullness, belly pain, all of which are sort of unexplained. They're not short-term. They come on and don't go away. It's not things that people have had for 10 years. There are people that have had abdominal symptoms for 7, 10 years they're figuring it out, they've had workup for it. It's that there's a new onset. It's usually later in life. And then some patients present with jaundice. That's one of the initial presenting symptoms. So I think what people should be aware
Help
of.
us understand those of us that may not know what jaundice is. Help us understand what jaundice is.
So jaundice is where the bile flow in the body is blocked, and that leads to a yellowish coloration, and that can be easily seen in your eyes, in the fingernail beds. And most times, I've seen patients, because we look at ourselves every day in the mirror, we don't really recognize, even when we're getting yellow colored. It's usually a neighbor or a friend that'll come and tell you, I think you look a little yellow. And that's definitely a big red flag. Need to get care right away if there is any jaundice. And like Dr. Asifov said, that there is a diabetes link. People have been on, that are known diabetics for decades, suddenly start to get their blood sugar out of whack. And they tell you, I haven't done anything different. I'm losing weight. I can't explain why, and my blood sugars are out of control. Or that they've never been diabetic, and now suddenly their blood sugars are out of control. These are all telltale signs that we need to evaluate the pancreas. But at the same time, I want to put a word of caution. Is that not everybody with belly pain has cancer. It's a very small percentage of those patients have cancer. So there's no need to panic, but there's a need to see a doctor and get everything evaluated.
Absolutely. So is there a way to screen for pancreatic cancer so it can be diagnosed at an earlier stage? Because I know we were talking about it being caught late because there's not a lot of, there's not a definite symptom mix, but is there a way to screen for it so it could be diagnosed earlier?
Well, so screening is a great tool. We have it for a lot of cancers. Unfortunately, for pancreas cancer, because it's not a very common cancer and there's not a simple screening test. Right now, the recommendation is that we don't need to screen everybody. Only people that have symptoms, a family history of cancers. There's generally a pattern of family history of cancers. And if you have a family history of pancreatic cancer in your family member, especially mother, father, brother, sister, I think it's time to get genetic counseling at that point to see whether or not you have other gene mutations that may put you at a high risk for cancer. Or even if you don't have the genes, having that family history itself means that there's something we don't understand yet that's being transmitted from generation to generation, that's putting them at risk for pancreatic cancer. So we divide patients into high risk and average risk. And screening is indicated in the high risk group. Generally, we do what's called an endoscopic ultrasound. So it's basically a scope that's passed through the mouth once the patients are fully asleep under sedation. And it's placed in the stomach, and through the walls of the stomach, we use an ultrasound technology to look through into the pancreas. It gives really good images, very good view. But again, it involves coming to the hospital, having sedation. So we try to balance that and do what's called an MRI. It's sort of an imaging tube that you lay in. It uses magnets to develop images, to get images of your body and your pancreas. It's a very good way of looking at the pancreas non-invasively. So yes, there are screening tests, and these tests are for high-risk groups at this point in time. And at Cedars Sinai, we have a special program just built for high-risk patients, especially with the genetic mutation or with a family history, so that they can be screened every so often to detect the pancreatic cancer early.
Just as a quick follow-up, help our audience understand where the pancreas are located in the body.
Oh, great question. So I was looking for a picture to show that, and here I have something I can show you. So pancreas is located in your upper belly. So it's right here, just below your chest in the mid portion, and it goes it goes from the right side of your belly all the way to your left upper part, just underneath your lowest ribs. It's located all the way back. And so, it's a very well protected organ. It was one of the last organs in the body to be detected in the belly. It's generally the pain and symptoms associated with it occur in your upper belly, and they go back they radiate to your back. That's what we say when it hurts somewhere, but then the pain ends up elsewhere. So there are patients that come in and say, well, I think I have back pain. I have some belly pain, and then it goes to my back. So those are classic symptoms that are supposed to be coming from your pancreas.
Right, that's great information, because it's like I as much as I've done a lot of these programs, I didn't even know where the pancreas was. I just knew it was in there, but I didn't know where it was. So that thank you for that explanation. Dr. Osipov, how is pancreatic cancer diagnosed?
So Dr. Gaddam brought up a few good points about the first symptoms, right? And those symptoms by themselves can be related to other conditions. But I think you always have to exercise a high index of suspicion. In other words, if you start getting a few of those symptoms together, you see your doctors, and they start with initial workups. And that typically involves a lab test or blood draw, where they take your blood and they look at your liver function. And sometimes they see abnormalities there and the things that reflect any type of blockages and what Dr. Gaddam described as the bile duct. That's one place. So lab tests are important. The next part is, because where Dr. Gaddam showed the pancreas is located, you need kind of very unique imaging. And that imaging can involve a few things. Like, for example, it can involve an ultrasound, which is, they use sound waves to look at the pancreas and the organs around it to see, is there something abnormal in the pancreas? The other very common tool that we use is a CT scan. The CT scan is actually probably one of the best ways to look at the pancreas and its relationship to all the blood vessels that are around it, which is really important for determining the best path for treatment. Other things that we do are MRIs, as Dr. Gaddam mentioned, but the critical part of diagnosing pancreatic cancer is a biopsy. And a biopsy typically is done in the similar procedure as Dr. Gaddam explained, where they go in through the mouth endoscopically, where they first can look with an ultrasound from the inside. And then if they see something abnormal, Dr. Gaddam and his team can actually go in with a needle and take a piece of that part of the pancreas that looks abnormal. That biopsy is very, very important, because that actually confirms whether there is cancer there in the pancreas. Not only is it important to confirm it, but it's also really, really important because it actually helps us to figure out best possible treatments for patients. And these new tests that we have, which are special genetic testing we do, we can actually do it on that biopsy specimen. So really, it's labs, specific imaging we do, as well as the biopsy, which is the ultimate confirmation of the cancer.
Let's bring in our genetic counselor to talk about genetic testing. Who should undergo testing for these genetic markers? And if a patient is positive for one of these high-risk genetic markers, what does that really mean? And how should they proceed if they're at risk?
Absolutely. So as Dr. Osipov mentioned, we've learned that about 10 to 15% of pancreatic cancer can be driven by an inherited risk, something that was running in the family. And I always tell people the best person to have genetic testing is the person with the cancer themselves, to really figure out, do they fall in this 10 to 15% of having a genetic or an inherited risk factor for having developed the cancer? So if it's possible, if there is a person who has a diagnosis in the family, I recommend they ask for a genetic counseling referral or for germline genetic testing, which is the kind that's looking at the genes a person was born with, the genes they've inherited, half from their father, half from their mother. These are all genes that we all have in our bodies, and they work to actually protect us from cancer. But a genetic test is trying to see if maybe there was a problem or a mutation in the way that they were working that was present from birth. Now, what does it mean to have a genetic risk factor or a genetic mutation? if a person does come up positive to having a mutation in one of these genes, it does not mean they're absolutely going to get a cancer in their lifetime, but it means they have less protection. They have less of the protective factors, and their overall lifetime risk is elevated above average. It's higher than the average person's. So as Dr. Cheatham was mentioning, we're often trying to figure out who falls into the average category and who falls into the high risk category. So learning about an inherited increased risk may allow a person to have increased or specialized screening for pancreatic cancer because they are born with these genetic differences. Some of these genes have risks for other cancers like breast and pancreatic, or ovarian and colon and pancreatic. So there might be additional screenings that a genetic counselor would recommend based on a genetic test result.
And I guess the biggest question is genetic testing covered by insurance?
Yes. So the short answer is in most cases, yes. So it should be covered for all patients with a diagnosis of pancreatic cancer. And if that person is not available to test, I do recommend it for close relatives. So parents, children, siblings, people with a first-degree relative with pancreatic cancer. Most insurances do cover the cost of testing. Working with a genetic counselor, we can, oftentimes get some of these tests covered by insurance. And even if insurance has denied testing or declined testing, there's really options that are a lot more affordable, somewhere around $250 for patients with different patient assistant programs as well with labs. So in short, they are essentially mostly covered, but if not, there are certainly options to having the testing done.
Yeah, that's for folks, that's a big thing. We got to make sure that it's covered. So Dr. Cheatham, if now you've gone through the screening, you've been diagnosed with pancreatic cancer, all right, what treatments are available for somebody that has been diagnosed and confirmed with pancreatic cancer?
Yeah. So I'll try to give an overview, but Dr. Aspav's the expert in treatments. He sees patients every day, so I'll defer to him after that. So in general, in any cancer, the goal is to resect or cut and take the cancer out of the body. That would be the overarching goal. But what it requires is, we have to make sure that it can be done safely, effectively, and that would produce a lasting impact on the patient. Right. And in order to achieve that, oftentimes some sort of a systemic treatment. When we say systemic treatment, we're talking about treatment that goes through our mouth or through the veins in order to reach every part of our body and to cleanse it of the tumor. So that's a chemotherapy agent, or that's called chemotherapy. That's what would be used. Sometimes it may become necessary that in order to get the patient to a point where they are eligible for surgery, or they can have the best chance of getting the cancer fully out of the body, is to use what's called radiation therapy. So radiation therapy focuses, type of X-ray therapy, X-rays into that particular area to kill the tumor. So these are the three different types: surgery, chemotherapy, and radiation that are available. But I'll defer to Dr. Asapov to add more to this area.
Yeah, no, that's actually a very important overview that Dr. Cheatham gave. The part for treatment that's also really, really important. Dr. Cheatham highlighted three different kind of types of treatment that are necessary for all the patients with pancreatic cancer. One of the very critical aspects is that, and we do this at Cedars, is that you get evaluated by experts in each aspect of that treatment. That is vitally important, right? You need a very good gastroenterologist to help with getting the tissue. You need a radiation oncologist to go in and see, do you need radiation to give those x-rays? A surgeon to say, hey, is this the right time to take it out, or do we need to give those therapies before? And a medical oncologist, where they come in and say, yes, we need to give a very specific type of chemo, or assess for clinical trials, or novel things that we're doing, or new types of treatments. And at Cedars, we actually have a very unique program where what we do is, because on average, we've seen that in the community, it takes sometimes 4 or 5 weeks for patients to go from suspicion to ultimately getting a diagnosis and a plan for treatment. What we do is we try to bring all these experts with genetics, dietitians, which are also really important in the care of these patients, social workers for all the other needs that they may have, and the supportive care team, all in one day over 4 to 5 hours, where we see these patients together. We come together as an expert team, and then we come up with a plan to see which one of those modalities or treatments that Dr. Gaddam kind of brought up would be appropriate for these patients. Because some patients, maybe surgery isn't the appropriate thing. Sometimes we have to just give them chemotherapy. Some patients, maybe they need chemotherapy and they need radiation and then to go to surgery. Or maybe they're a good candidate for clinical trial. So this is the kind of the ideal way to approach the care of these patients for treatment.
So if I may add to that, I'd say, this is just an example. Yesterday, I had a patient diagnosed with tumor. Today, I have the biopsy back. I've already sent them a comprehensive, I've already referred them to see Dr. Asipov and his team, which has a very comprehensive approach. So Monday, the patient was here. By next Monday, they'll have a complete plan in place to move forward. And so this is generally, the timeline takes much longer. And this great program that Dr. Asipov has created is now making things much better for the patient.
Absolutely. So, there's advancements in medicine happening all the time, and particularly in cancer treatments. It's happening daily. So can you share any new treatments underway at Cedars that are helping bring hope to patients with pancreatic cancer?
Yeah, I mean, that's a very important question. And probably in all reality, we can spend a full hour talking about it, but I think I'll highlight some really big examples of the multiple really important parts for advancements that are happening in this field. I think everyone's pointed out that this is, it is an aggressive disease, and we're trying to get ahead of it. One part of the advancements are there tools that we can use to better predict how patients will do? Because we don't really have great tools. We have some blood tests as of today, like
Right.
tumor markers. But for example, Dr. Gaddam has an excellent study where we use new technologies, MRI, for example, where we take pictures of patients right at the time of their diagnosis, and then we take multiple pictures over time. And we use artificial intelligence or very powerful computers to predict how a patient will ultimately do. Is there something specific on their imaging that may help us as physicians to better figure out a good treatment option? That's one really important aspect. Along with that, there's research that we're doing with new tests to try to detect the DNA of tumors in blood to help us figure out, is a patient responding, or is the tumor coming back earlier, right? These are questions that come up often. Now, I'm sure that a lot of people always hear the word about immune therapy. Immune therapy, it came out about 12 years ago. The scientists that discovered won the Nobel Prize, and there are cancers that before they were incurable, like advanced skin cancer, like melanoma, or advanced lung cancer, where before patients would be living 1 year, but now there are patients that are living multiple years that don't have any disease when they get this new drug like immune therapy. Now, in pancreas cancer, this drug by itself doesn't work, but we have research where we take these new immune therapy drugs and drugs that make our immune system better to hopefully attack and get inside the tumor. That's one novel aspect. The other thing is we take sometimes chemotherapy and other special targeted drugs where it specifically goes to a part of the tumor that's changed. Like there's something specific in their genetic code. And that's why when we take the biopsy specimens for patients, we do special genetic testing. And if they have that mutation, we have clinical trials that specifically target that change in the tumor. And you actually avoid the chemo. You get a very specialized drug, less toxicity, and this works better. These clinical trials are really, really important. And, at Cedars, we're very fortunate. We have a very big program with our entire team, over 15 clinical trials. But oftentimes we see that patients either hear too late about them and not early enough, where if they know about it, maybe they're not a candidate on day one, but at least them and their physicians have a good idea for the future should they ever require it.
You mentioned that we talked about that throughout the program, clinical trials. We did a program earlier today on clinical trials, and we had a patient come on and talk about his bout with leukemia and the fact that he was given 3 years to live, and now he's, here it is 30 years later. He was diagnosed in 1995. And it was because he participated in the clinical trials. And it wasn't just one trial. And so you think that, hey, I participated in clinical trials. He went to multiple. He was engaged in multiple clinical trials. And he attributes, by participating in those other ones, that got him to the one that actually worked. And so, it's important to, we're going to talk about that. So before I ask my next question, we have a short video that we're going to play, and it's about clinical trials.
Had an opportunity to think about myself, always putting my health last. Cancer came my way. I'm not going to say it's easy. It's really been a journey. Doing nothing is not an option. If you are put in a position to make a difference, take the chance. So with the trials, someone took a chance. That's why I'm sitting here today. Be a part of the solution of life.
For more information on clinical trials, call 310-423-2133.
So the question that I have now is, Dr. Osipov, what about clinical trials? When is it appropriate for patients to ask about clinical trials, or is that strictly driven by the physician? And how do clinical trials help patients with pancreatic cancer or other types of cancer?
Yeah, yeah, I would say day one. If you find out, and it's always patients, and Don will speak about this, but patients, when they hear about that diagnosis, there's a lot of information that comes their way. But I think one thing to remember is on day one, you should always engage your physicians, whoever it may be, about clinical trials. Despite our best efforts, whether with all the treatments we discussed, we know that this tumor can come back. We know that it actually can also impact their quality of life. Clinical trials are not just only meant for helping the outcomes or prolonging survival or getting rid of this tumor, but it's also to improve their quality of life, whether it's gaining weight, feeling better. And there are trials that actually, even at Cedars, we have designed specifically to make quality of life better as you go through this. So it's really important that on day one, or when you meet the oncologist or the whole team, that you ask, what clinical trial options do I have? I know that there is chemo, there's radiation, there's surgery. These are things that I know I may or may not be eligible for, but is there something new? And the reason why clinical trials are really important is because they take what we already do and they add something else on top of it. And that something else is based on research that we do at Cedars, as well as in throughout the entire country at big academic centers that are focused day in and day out about how do we cure this disease. So we take that research and we design trials to make the chemo work better, the radiation work better, surgery better, or to detect the tumor earlier. And by participating in these clinical trials, patients have a chance to have a better outcome. There are patients like the one you highlighted that they maybe went beyond what was expected. No one is a statistic. Every time they say, oh, how long do I have, or how bad is this going to get? No one is a statistic, and we don't know that. And maybe by participating in a clinical trial, trying something different beyond what we normally do, which is called the standard of care, they may have a better outcome. And we always advocate for that. And even if a patient, they go in and say, hey, today, at least where you are, we don't think a trial is today in your best interest, or you're not a candidate, that doesn't mean there won't be a candidate later on in time. They may require it. And if you participate in one trial today, that doesn't exclude you from a trial later on. And these trials are designed with first and foremost, with a patient's best interest in mind, and to ultimately make a meaningful outcome for all patients that are diagnosed with this disease.
I think it's also important to note that clinical trials are not always just about creating medications, right? They are about treatments as well. So orders of treatments, combinations of treatments, how and when do they take place? So there are multiple ways that clinical trials, come into place. And when we're talking about people participating in clinical trials, whether you're a patient or whether you're just somebody off the street that wants to participate in a particular study, understanding that it's not always about developing new medications, it's about developing new treatments and treatment combinations that could be more effective for somebody either now or in the future. So please, that's my stance on I want everybody to participate in clinical trials as much as they can. So let's turn and let's hear from somebody who has been through a diagnosis of pancreatic cancer. We're going to introduce Donald, aka Don Cheatham. Don, would you help us tell us about your experience?
So I was diagnosed on April 6th with stage 4 pancreatic cancer. My type is what is called acinar cell, which less than 1% of all pancreatic patients have. Very devastating when I heard the news. I'm a tax accountant, so that I found out the last 2 weeks of tax season, and it just hit me like a rock. But at that time, I began to I had I'll back up. My sister called immediately after I got the diagnosis. She was calling, and I told her, and she was the first voice that came to me that was just like of calm, knowing that this is not my destiny. And she felt that wholeheartedly. She told me that, and she said, I need you to take a deep breath and call your wife. And from that time, I did what I would suggest no one else to do, is go to Google. I wouldn't, suggest you not do that because that's when you'll start reading things that, that I feel like some of the data is just kind of outdated and so forth. But it definitely put me in a, upset, scared. I didn't know what to do. So I did the next best thing, which was get on my knees and pray. And God told me that this was not my destiny and that he wanted me to share my journey as I go through this. And so, it's a true believer. And then I took the steps from there, as the other doctors said, to contact my main physician, as well as I had a good friend of our family who is she's an oncologist, but for breast cancer. So she contacted her head of the pancreatic unit at Piedmont, and they got me in immediately. And from there, he gave me, exactly what I had, broke it down because I didn't understand the acinar. All this is brand new, right? You just hear cancer, you get the diagnosis, and you're just like, yeah, you're just like, devastated. So like he said, that's like Dr. Osnoff said, you have a lot of information that just comes at you quickly, and you have to pretty much, grab the car and take control of your situation, because if you don't, no one else will. So you have to be, you have to drive your vehicle through this. You have to put your team together, and you have to feel comfortable with who you're going to ultimately go with as your primary care. I got several recommendations. I went to MD Anderson in Houston. Came out here to Phoenix to Honor Health, and I also went to Memorial Sloan Kettering in New York. Got everybody's recommendation, and I felt most comfortable here at Honor Health with Dr. Borrancy. And he did a great job of just breaking everything down to layman's terms so I can understand what exactly, showing me exactly where it was located, where it was located in my liver, as well as his approach was just, like I said, totally different, than the other doctors were saying. And I felt like I wasn't just going to be a file number. I was going to be someone that was going to be looked at as a human being that, who he's trying to save. So.
Don, you mentioned it in your response. I want you to kind of talk to the importance of having a team around you, supporting you in this process. And I think Dr. Osipov mentioned it as well, talking about having that team supporting you to help you through this process, because it's difficult enough as it is to go through this alone. It's almost impossible. So talk to us about the importance of having that team around you.
Yeah, so I've had two good friends, not with the same cancer. One had a stage 4, very rare. I can't think of the name of it. It was dealing with the saliva glands. And I called him maybe day 2 of finding out. And he was able to come over, talk to me, because he wanted to make sure that I was just in a good space mentally, right? And also give me information he broke down a lot of walls for me in terms of, steps I should be taking, understanding, as he would say, guard, as I've taken on as well, guard your mind, guard your heart, because you're going to hear tough things and you have to be able to, work your way through that. I had another good friend. She had breast cancer and she's a breast cancer survivor. Now let me say back to the first person, he was diagnosed where he was told to pretty much get his affairs in order. Here we are 9 years later, and he is, his is in remission. He's fine. And moving forward. So, it's one of those things that it started with those two. And from there, those two were telling me, you have to put your team together. And, with mine, I'm not only, going about it from the Western medicine, I'm also doing some things, acupuncture. I'm doing definitely nutrition, right? So I've immediately cut out meats, sugar, dairy. So most of my diet is made up of just fruits and vegetables, and some fish, and then, from there. So got lots of books, did a lot of reading very quickly, and in like a 2-week span of just trying to figure out just a different approach that people had, told me about. And of course, like I said, I've been sharing my journey. So, people have been I've been meeting other people. I actually met another doctor who was diagnosed with the same acinar cell that, this is how I even found out about Dr. Borrancy from Piedmont, because they were caring for this person. He just finished his treatment plan. And he reached, he was fine with me reaching out or us talking, because I asked him, could there be someone else? That's also important to see someone else who's gone through the journey. And although he just finished, he has information and he's a doctor. So, he has other additional information he can assist with. And he's been great, very, open about his situation where he's at right now. It is, his has been removed pretty much from the liver, and his is benign in the pancreas. So, they're now going after, he's taking medicine right now to deal with the BRCA2 gene that he has. That's what his situation is. I have what is called a CHEK2 gene mutation. So, I'm assuming I haven't figured out what's going to be my course after this, because I'm now 5 treatments in so far of doing chemotherapy.
Right. So we talked about, genetic testing earlier. So do you have any family history of pancreatic cancer, or do you have any siblings or children that now we should get some genetic testing to see if there is any possibility to have that same kind of genetic predisposition for pancreatic cancer?
So no, I didn't have anybody else in my immediate family with pancreatic cancer. My grandmother, maternal grandmother, had colon cancer, which they caught in the early stages when she was 70, but no one else with pancreatic cancer. I do have a 2-year-old daughter, so I would, when she's of age of being able to go through this, the genetic testing. I'm not sure what the first age, and you can probably, Lenore, you could probably chime in on that, but I would definitely want her to go through it as well, go through the testing. As well as I have a brother and I have a sister, but my sister and I have the same mom, different dad. My brother and I have the same dad, different mom. Not sure if that makes any difference through this process. That's something else maybe you can speak to as well. But I would recommend them as well to get tested, just to be, I recommend, since these numbers have been increasing, and I was going to chime in earlier, but I know it's just you were talking to the 2 doctors. I recommend that people try to get tested sooner than later, because like you said, you don't have any symptoms that really are, unless like the ones you listed. And I didn't have any of those symptoms. I happened to get a gaseous feeling on a Monday that felt like I just ate something that didn't agree with me, but it didn't. It kept going away through Tuesday through Thursday, and then Friday it hit me again. And my wife's like, "You should go get that checked out, just to make sure." So I went to urgent care first. They saw the gas, I took an x-ray and saw the gas, but she's like, because it's also in your lower part of your abdomen, it could be, she was thinking it could be gallbladder or appendicitis, so forth. And so she said, I recommend you go to the ER. and went to the ER. They ran blood tests, didn't see anything. And then the doctor's last was like, I think we should just do a CT scan to just make sure. And that's when they caught it. So, saw what they deemed it to be. I went through the MRI the next day, and then which was Saturday, and then that following Tuesday is when I had the biopsy, and I got the diagnosis a week later. So,
I think there's an important lesson in that, Don, is that you did the follow-up steps, right? And how many of us stop along that way? Because you had to go from just a gaseous feeling. Some people would say, oh, they'd have drank some ginger ale and kept it moving, right?
Kept going, correct, yes.
But you went and got that checked out. And then they said, and then you had to go through several doctors before they were able to catch it. If at any point you stopped along that way, we could be having a whole different conversation. I think people, when we're talking to our audience and people are watching this today, understanding about being your own best advocate, right? And so
absolutely.
This is that statement. This is that moment where you say, I have to advocate for my personal health. And if I don't feel healthy, I'm going to keep going until I find out what's wrong or I feel healthy. And you can't stop. You can't get frustrated by the system, because we understand. We know there's a history of distrust. We understand all of that. But your health is the most precious asset that you have in your life. And so you have to protect it at all costs. And so I just want to give you a shout out for standing out and standing up for yourself and being diligent about, I'm going to see this all the way through to find out what's going on, versus like what many people do is that, the doctors don't know what they're talking about, and you move on and you really never got to the problem. So
yes.
That's so I had to get on my soapbox just for a minute, but I'm off of it. So
no, I mean, just to add to that, that is one of the main reasons I'm sharing the story, because I've had several people already tell me just recently that I've been having this pain for about 2 weeks, 3 weeks, or a month. I've been so busy with work, family, life, I haven't got it checked out. But because of hearing your story, I made an appointment to go to the doctor now and that's what it's all about, right? So people have to, sometimes here, I would say when I was younger, I wasn't going to get my checkups every year, right? But I had a friend who ended up having a stroke, and that was a wake-up call for me. I'm just like, I need to make sure that I'm healthy, and I want to be here. I want to live. So that's the question. You ask yourself, do you want to live? Do you want to be here? And I think a lot of people, the answer is automatically yes. Well, you have to do those. You have to take time. I mean, as I spoke before, I was in the middle of the heaviest time of tax season, and I stopped and took 5 days to deal with me. I can't help others if I can't help myself first. So it's definitely key.
Absolutely. Last question for you, Don, is so many of us have come to think of pancreatic cancer as a catastrophic diagnosis. Mm-hmm. How did you overcome that kind of thinking? And what would you tell others who received this diagnosis?
For me, as I spoke earlier, God-fearing. I got on my knees, and when I asked God, about this, His words were strongest. I'm talking to you today, and He told me that this is not my destiny, and that I have something far greater for you to go through. I'm sorry, but I have something far greater for you to go through, and I need you to listen. I need you to follow my words, and it will be revealed. So, that is something that I'm walking this out on faith, 100%. And I truly believe I'm going to be healed from this. I'm going to be here for my wife and my 2-year-old daughter. And our village is strong. I have to definitely give them the love, because they've been pouring in for messages and, from all over. I haven't heard from people for years. And so I definitely want to show them lots of love, and from the contributions that they've been giving to me and my family as I go through this, because this is an undertaking also with us moving and relocating from Atlanta to Phoenix, where I'm at right now, as I go through my first round of treatment. But the one thing I would just tell folks is, as I said earlier, you have to take care of yourself. You have to go through your appointments annually. Make sure that you are getting your getting the tests that you need to make sure. And I know, like you said, that a lot of these tests are not prevalent. I know that they've been working on new tests because we are seeing an increase in pancreatic cancer. I believe there are blood tests, though, that can tell, at least that's what my physician told me, that there is a test from blood work that you can tell that may be elevated. That may give them a sign that there is that you could have pancreatic cancer, but it wasn't included because that's not what's in the insurance is covering. So, but I believe there are a lot of people, if they knew that this was not included, but this could help them, they would pay for it themselves. And so, you know, you don't know not to ask. You don't know what is covered. I know I get my annual physical, and you get all these results, and you're thinking, oh, this has to be covering me from head to toe. But it comes to find out it's not always, everything's not included. So I think that's important to also ask, are there other tests that can be, you know, like pancreatic cancer, or if there's something that's not being covered, at least offer it, right? And let people be the, give you the answer. Yes, I want it, I'll pay for it, or no. So it's just, you know, a choice.
Absolutely. Yeah. Don, you got me.
I apologize.
No, Don, you know, the moment of transparency, you know, Don and I are friends and have been friends for years. And so, you know, whatever, you know, I remember when I found out, I texted him immediately and just said, hey, what can I do to help and try to help whenever I can. And then we were doing this program just, you know, randomly with Cedars Sinai. I hesitated for asking him because I didn't know how private, you know, he wanted to keep it, but he said he wanted to share a story. And I think it was important to have him here and whatever we can do to support, we're here. So Nanor, there was a question in the chat, and I think it's important, is what age can children of someone who has had cancer get genetic testing?
Yeah, that's a good question. And in terms of someone who's had cancer themselves, I don't think there's a strict age cutoff in terms of what age can a person have genetic testing. And it really often does depend on the type of cancer. You know, there are unfortunately some childhood cancers where genetic testing may be helpful. I think lots of people have questions about, you know, their children. I know, Don, that's something, you know, thank you for sharing. I think that's a big question that a lot of our patients have. And a lot of these genetic risks are really risks that come on in adulthood. Many of these genes, CHEK2, BRCA included, don't have risks in a person's childhood. So we often think of testing over the age of 18, because that's often when we might talk about adding on some screening, or, you know, even in a person's 20s, as we don't think a lot of the screening would change in a person's childhood or teens. And we would almost encourage them to, you know, live a normal childhood and have this information kind of in their back pocket, but it not be, you know, it be an option for them to decide when they become of age as well. So I always encourage people, even if they don't have a personal history of cancer, to kind of open up the communication about their family history. So there might not be the people available for genetic testing. Maybe it was grandparents or aunts or uncles or parents. But if you know there's that history in your family, I think it's important to bring it up to your doctor, important to know that genetic testing is an option, and even to talk to a genetic counselor who will take a full family history, educate about genetics, what is genetic testing, how can that be covered by insurance, and who's the best person in my family to have this testing. I think even if, you know, there isn't a diagnosis personally, if you know of a family history of pancreas, but also other cancers, breast, colon, prostate, there's some opportunity to discuss that with a genetics professional and talk about testing.
So Dr. Gaddam, as I continue to put myself together, is there anything we can do to lower our risk of getting pancreatic cancer?
Yeah, so Alice, that's a great question. We don't have a perfect answer, but we do know that if you're smoking, stop smoking. There's several reasons to stop smoking. Pancreatic cancer is certainly one of them. Watch what you eat. You're going to, whatever it is that you're planning to eat, you're going to buy off the shelf. Just watch what's in it, because you're going to consume it. You're going to put it into your body. Be really respectful of that. And then again, I go back to what Don said: is be an advocate for yourself. Watch for what you eat. Watch your weight. There's a very good indication that obesity may be related to several cancers, including pancreatic cancer. So watch weight, lead a healthy lifestyle, limit your alcohol use, and take low-fat diet. So that's what we have at this point in time. That's what we know. So I'd say I'd underscore the importance of advocating for yourself and trying to do everything you can to prevent disease. And I want to thank Don for sharing his powerful story. Thank you.
Absolutely. Dr. Osipov, I got one question from the audience, and then I got one more question for you. The question from the audience is, how successful is a removal of the entire pancreas if the cancer is both on the head and the tail?
So you can remove the whole pancreas, but still the thing that comes up is when you do any type of surgery in the pancreas, it's also very important to still give chemotherapy. And the reason this comes up is it's very successful. It removes it, but oftentimes we know that little cancer cells, they go and they hide. They hide in various parts, and these aren't things that we can go easily cut out. So what we often recommend is you do the surgery, whether it's part of the pancreas or much more of it, but you follow it up with chemotherapy so that you can take away those small cancer cells that are hiding so they don't come back one day. So that's a really, really important point.
And the final question is, what's one takeaway you want our viewers to know today about pancreatic cancer?
So, kind of building off with the important story that Don shared and everything that Dr. Cheatham had mentioned about the risk factors is, you got to, as Don mentioned, take control. And sometimes you actually need to take control early on before you even develop any type of cancer. Take control, ask your family members, know your family history. Is there something in my family history that raises my risk? Are there things that I'm doing in my lifestyle that raises my risk of developing pancreas cancer? Am I overweight? Am I not eating healthy? Am I smoking? And maybe I can modify these things so that I don't get this cancer. These are important. And if you do have these risk factors or you're in that high risk category, maybe then you should undergo screening. So that's really, really important, talking to your doctors about that. And if by some unfortunate chance you or a loved one that does have that diagnosis, as Don mentioned, you need to take control. Find a team of experts that you feel comfortable with, ask all the right questions, and keep asking questions till you feel comfortable, and then come up with a plan and then move forward with that plan, and do not give up at any point along the way. Always stay in control, as Don has done, and you can do it from starting even with the way you are today, even if you think you're healthy. There are risk factors that all of us are exposed to, and maybe we can do a better job at this. So that'd be my real takeaway point.
Absolutely. So Don or Dr. Cheatham, this question, what's the name of the cancer test that you can take for screening?
It may be that Don was probably alluding to what's called CA19-9. Is that right?
That's correct.
So it's a good test, but right now there are some issues with the test itself. Sometimes it can miss some cancers. It can overdiagnose people. So it's a good test for a select group of people. So I'd say it's not for everybody. Please meet with your doctor, talk to them, and see if that's right for you. And it doesn't hurt to bring that up with your doctor when you see them.
Absolutely. Well, we'll get some fast and furious questions. These are quick ones, though. Is it recommended to get a third opinion? I know we talk about getting a second opinion, but is it recommended to get a third opinion?
Well, I can speak to that. I ended up getting 4 opinions total, right? I was told, if you see somebody and they have a problem with you getting another opinion, then that isn't the right person for you. So no one had a problem. They just didn't want me to get bombarded with a whole bunch of recommendations, but I did get 4 opinions. And like I said, when I set everything up, I had them all in place. Once I came here, I kind of knew this is where I was, I knew after I left him, this is where I was coming. I followed through with the other appointments because I had them already set up. But unless they said something that was going to be, 100% change my mind, which they didn't, it made it easier for me to just come back and come to this doctor. So it is important, I think, for you to get recommendations. And because, you don't know. I'm not a doctor. I didn't know much about pancreatic cancer. And like I said, you don't want to Google because it can be, be detrimental, I think, to you in the early parts of trying to understand this. So you'll know who you need to, you will know who the right person is once you come upon them. I was told that was the knowledge that someone gave to me. And sure enough, when my wife and I walked into the appointment and we opened up, about an hour in, I knew he was the right person.
Absolutely. So, Dr. Osipov, can a patient get clinical trials if they are being treated at another facility?
They can. There are trials that you can get, for example, part of your treatment at nearby or a different facility, and the portion that's going to be the new drugs can be given at a different hospital. That happens. And sometimes patients complete a portion of their treatment, whether it's chemo or radiation or even surgery elsewhere, and they can go on a clinical trial at a different site. Sometimes it requires for you to be at a particular hospital, but there are many clinical trials, and that's why it's important to ask, because there may be clinical trials where you can kind of split the way you're getting your treatment. It's on a very individual case-by-case basis, but that can be done.
Well, thank you all. Thank you all for the questions. Don, I tell you, I would encourage you to go and read the comments. I don't know if you've been reading them throughout the program, but they have been fully supportive of you and your situation, and just really just been great. So thank everybody for the comments. Thank you all, Dr. Cheatham, Dr. Osipov. I know everybody has been fantastic today. There was one thing I want to make sure that we recognize that when we're here today and we're talking about pancreatic cancer, we do have to recommend, and I'm going to put this on screen, that this event is for informational purposes only. It should not be relied upon as medical advice. It has not been designed to replace a physician's medical assessment and medical judgment. Always consult first with your physician regarding anything related to your personal health. So this is just informational purposes, and should not be considered or replace your conversation with your personal provider. Just want to make sure that we understand that information as we're wrapping up here today. I just wanted to say thank you to our friends and our partners at Cedars Sinai for this informative discussion. Thank you, Dr. Cheatham, Dr. Osipov, our genetic counselor, Nanor, and our amazing patient, Don Cheatham, for joining us today. We promised you a conversation that could possibly save your life, and I think we have delivered. Make sure that you know your family history and get your genetic testing if you fall into the high-risk category. By being proactive, you are helping yourself and your family members be informed patients. Remember that early screening and detection saves lives. We'll be sharing resources in our chat, so make sure to check those out. Thanks so much to Cedars Sinai from all of us here at blackdoctor.org and Daily Vitamina. We want to thank you all for being here with us today. This has been an amazing discussion, and I cannot say more about everybody that's been on this. It's just been fantastic. So I want to say thank you again, and we look forward to our next community conversations with Cedars Sinai. You all have a wonderful evening.
You too. Thank you.
Okay.
Thank you.
Thank you.